From theheart.org, Medscape Cardiology, this is the Bob Harrington Show. Dr. Robert Harrington is the Stephen and Suzanne Weiss Dean of Weill Cornell Medicine and Provost for Medical Affairs of Cornell University. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
Hi, I'm Bob Harrington from Weill Cornell Medicine in New York City, and I'm here on Medscape Cardiology and theheart.org. What I always try to do is have a conversation with one or two people about something that's topical in cardiovascular medicine. But this time, the topic is so important that I'm having a conversation with three of my colleagues who I think are real experts on this. And the topic is the National Institutes of Health and where we're going as a country, as a research community with the NIH, specifically with regard to the direction of funding from the NIH, something that all of us in academic medicine, certainly, but all of us in society should care about. And I'm going to use the recent publication of a presidential advisory from the American Heart Association that talked about the future of biomedical research in the United States and how to optimize research coming from the NIH from the perspective of the Heart Association, the second leading funder of heart and stroke research in the country. Three of us on the screen are authors of that paper, co-authors of that paper. And one of us on the screen is the leader of a major clinical research institute. I think we'll get some good insights into how people are thinking about the NIH, how people are thinking about the future of biomedical research funding. So with that as background, let me introduce my colleagues. First, Dr. Svati Shah. Svati is a professor of medicine at Duke University, where she's also the associate dean for translational science. And Svati is also a member of the AHA board of directors. So Svati, welcome. Next is Adrian Hernandez. Adrian is the executive director of the Duke Clinical Research Institute, a longtime, well-funded NIH investigator who runs a large research institute that is also the recipient of NIH funding in the areas of translational, clinical, and population health science. Finally, my good friend Joe Wu, recent past president of the American Heart Association, professor of medicine and radiology at Stanford University, where he directs the Cardiovascular Research Institute. So Svati, Adrian, and Joe, thanks for joining us here on Medscape Cardiology.
Great to be here.
Thank you, Bob.
Joe, why don't you kick us off? Because you were the president where a lot of these ideas began to emerge, what became the principles of thinking about the NIH and the future of biomedical research. Talk to us about how the paper came to be, how the working group came together, and sort of the big picture ideas. And then I'll get into some of the individual questions.
As you all know, this year, the AHA celebrated its 100th anniversary. And I would say that for the past 100 years, our organization has been dedicated to reducing death and disability from cardiovascular diseases. And outside the NIH, the AHA is the second largest funder of cardiovascular research. Since 1949, we funded more than $5.2 billion in this area. So I think we're tied quite closely to the NIH, which I call our big brother. As the audience knows, there's a lot of mistrust. There are a lot of advices that different parties provide to the NIH about what they should do, what they should not do. We wrote this document mainly to highlight what the important roles that the NIH have played. And I think that it's important for the audience to understand that NIH, lays the foundation for biomedical research, supports a lot of our young investigators, supports a lot of our mid-career and senior career investigators. Outside of cardiovascular science, the amount of funding that goes into different areas are very, very important. So my goal, or our goal to write this article, was just kind of lay the foundation, tell the audience, inform the audience what NIH is doing and how important of it will. It might need some tweaks, but overall, it serves its mission quite well.
Yeah, great. Thanks, Joe, for setting the stage. And Svati, let me ask you, because you bring several perspectives to the conversation, one of which is that you're an independent investigator with a long history of securing NIH funding over the years at Duke. You also serve as the associate dean for translational science. And then you have a couple of AHA roles, one of which is you're the past chair of the research committee, which is an enormous responsibility for helping determine the direction of AHA funding. And you're a member of the AHA board of directors. So put all those hats together And as you got called by Joe to participate in this paper, what were you thinking we ought to be trying to accomplish?
I'll start first by saying that I personally cannot underemphasize the importance of the NIH and the funding that comes from the NIH. It fuels science, it fuels research and discovery, it has economic impact. And something that I'm very passionate about is how do we train the next generation of scientists that are going to take care of the four of us when we're in the hospital? So the NIH funding is important for those reasons, but in thinking about my role as chair of the American Heart Association Research Committee, it also amplifies the impact of our AHA research dollars. And, all of us take care of patients, and I'm actually at the hospital today. The NIH funding and our American Heart Association dollars literally influence every interaction that we have with our patients and the way we take care of our patients. Bob, as you know, and Joe and Adrian know, at the American Heart Association, we've been thinking a lot about our own research processes. How much do we want to fund? How do we give out our funding? How do we measure impact of our funding? And in that light, what kind of impact do we want to have? What are the aspects of public health that we want to have with our research dollars? And so, with that framework of how we've been thinking about it at the American Heart Association, when Joe called me and asked me to be part of this paper, my brain was in this space of let's think about this in the context of the NIH. Yes, absolutely, the NIH funding is really important, as I already said, but same as we've been thinking about the AHA, what are areas that we want to help enhance impact and provide some guidelines around that so that we can have a continued impact on public health?
Yeah, I'm particularly glad, and we're going to get to it about training, one of the principles of training the future. I've always been struck by the statistic that Joe likes to quote a lot that I think if this is right, Savati, 75% of our research grants at the AHA go to early career investigators. So we're there doing it, but we can't do it alone.
That's correct.
Adrian, I'm going to start walking through the principles that were laid out in the document. And the first one, I think you'll know why I started with you, because there are also some words in here that are in the DCRI mission statement, the Do Clinical Research mission statement. And the first principle is to prioritize high quality biomedical research that is innovative and impactful. And certainly one of the things that your research group, my former research group, really tries to strive for is to be innovative and impactful. So do you want to build on that a little bit? I think this is a good first principle that we started with from the AHA, but as somebody who runs a research institute, how does this resonate with you?
Yeah, no, this is very clear. And if you think about the story about NIH and the AHA over decades, everyone around the world has been jealous of the research ecosystem that we have in the US. It's always been really creative, bringing new ideas from discovery to population health to bear. It's also been really important in terms of actually developing new concepts for treating disease and actually preventing health problems. And so it's really vital that this enterprise that has such a huge impact across the US in every corner is not only robust, but actually matches the needs. So as healthcare dollars have gone up, largely the NIH funding has been flat or actually going down based on inflation adjusted dollars. And so if we're going to meet the need to be innovative, we need to make sure that we continue to support the system and also do it efficiently. And so certainly embrace that.
So, Adrian, let me push you a little bit. What do you think of when you think of innovative research? Like, what does innovative mean, say, in the context of the kind of research you're more on the clinical to pop health stage, as opposed to Savati and Joe, who are more on the basic to translational. Tell me what you mean.
One is being very patient centered. So meeting the patient or the person where they are. And so that means actually having research be able to go across every corner of the US, not necessarily having people come into so called our ivory towers to access cutting edge research. We should reach them where they're at and also at the moment they're at. People are sick, they have problems. Let's fit into their lives. The second thing is actually bringing all the different disciplines of science together. So this panel that you brought together is exemplary of that. And so I've had a lot of fun working with people who come at the problems from different perspectives, different expertise, and different experiences. And so it's that kind of team science that can make a huge difference in terms of spurring innovation and actually developing new ideas that translate into everyday health.
Joe, let's think about the other word, impact. You're a laboratory scientist, but you also have the vantage point of having been the recent president of the AHA and seeing sort of the globe. What do you mean, or what do you think we meant in the document by impactful research?
I think the word impact conveys several meanings. Just like Adrian mentioned, if you look at this panel, I'm more of a basic scientist. I think Svati is translational, and then Adrian is more of a clinical scientist. In terms of my own career, I got my very first grant from the AHA. My second grant was a KOA grant from the NHLBI. And what we've been doing, it's trying to understand a lot of the mechanisms of stem cell biology and regenerative medicine and gene therapy and so forth. A lot of those are actually being translated in other fields into the clinic these days. These type of research that takes a long time to implement, and the understanding foundation that we built from the basic science all the way to translation to the clinical, it's not overnight. And so I do think that the NIH should continue to fund on all areas rather than just focus on one particular pocket or pot of money dedicated to one particular group of people. And so I'm a strong proponent of that. I hope that NIH will continue to do that in the future.
Svati, I'm going to go to principle number 2, which deals with the peer review process. And we wrote that it's to continue to improve efficiency and transparency in its peer review processes. It's not just coincidental that I'm asking you the question because it pertains to your role overseeing the research committee at AHA. Talk about this one. What's right with peer review? What's wrong with peer review? How would you advise the new leadership of the NIH to think about peer review?
I'm honored to say that I've given over 15 years of not indentured servitude to study section at the National Institutes of Health. And also, we've been thinking about this a lot at the American Heart Association and really looking at our peer review process too. I think there's a lot of fantastic things. We call it study section, right? For those of you who aren't familiar with this, this is we either get together in person or more recently via Zoom, and we're reviewing a portfolio of grants that have had some review before the actual study section happens. Um, I think over the years that I've been doing study section, I have seen that there's an even greater room for multiple voices, right? There's not as much of a single voice dominating the room, and there's more of an inclusive environment around who's able to make comments around the grants that are in front of us. Our recommendation would be to continue to expand that inclusivity by being more structured in the diversity of those review panels. That means diversity with regards to career stage, age, race, sex, the type of science that's done. Bob, as you know, over the past, 30 years, science has gotten more and more complicated. It's not a grant about a single thing. There's usually many different aspects of science that are embedded in these complex grants. And so there's really a need for diversity in the type of reviewers who are reviewing these grants. I guess the second thing I would say that we thought a lot about here at the American Heart Association, as well as our recommendations in this paper to the NIH, is making sure that we're doing training well of the reviewers ahead of time. Some of that training is about the specific grant, right? There are certain aspects of the specific grant that you're reviewing that you want to make sure the reviewer is keeping in mind. For example, when we think about these career development awards, part of it's the science, but part of it is like, is this person going to be somebody that we want to keep in science? So making sure that we're really thinking about training our reviewers, ahead of time.
Adrian, you may remember that when I was at DCRI, one of the roles I played is I served on the large trial study section for many years at NHLBI. And one of the things that always struck me about the importance of that was that, to Savati's point, it was an awesome study section because it was made up of really different individuals, clinicians, clinician scientists, biostatisticians, epidemiologists, data scientists. It was really, the diversity of thought in the room was really pretty incredible. But lately, one of the concerns, Adrian, is this, the independent study section is going to be done away with, and that more of it will be concentrated within the NIH. Now, part of my brain says, well, maybe that's not so bad because it'll get more efficient and be able to, people that really know the process can move things along. But I also worry about, will there be some loss of expertise? And hey, maybe there's a balance here that should be tested. What's your thinking on this?
Coincidentally, I actually joined that committee that you were on before, and actually just rotated off this past summer as chair. And so, through that lens, that clinical trials committee, I saw what you're exactly talking about, these different disciplines coming together across heart, lung, and blood to actually develop the best programs that should move forward in terms of the reviews. And it's very impressive in terms of my peers who are on that, in terms of the type of expertise that they're bringing together. And also, importantly, the main and a new addition is operational expertise. We had to have a project leader that was on that committee to say, this may be, even though you all scientifically say this is a great question, you have a fantastic innovative trial design, but you have no plan to actually execute. That was really important. So I worry about all those views coming together and how that's so critical. Now, certainly there are ways to actually streamline the process, because one of the things that comes up, if people don't get the question right, they don't have an important, impactful question, you could just stop there. And so other funding agencies are actually being pretty ruthless at the LOI stage, a letter of intent saying, this is not aligned, it doesn't meet a high impact area, and let people go on their merry way for the next one. Instead, we often have people who spend a year, maybe more, actually developing a grant and then submitting it. And certainly that's a huge opportunity to streamline the process. And as Svati notes, can make our time as reviewers more efficient on those that are most likely to have an impact.
Joe, I'm going to go to you, and maybe this is less your basic scientist hat and more your recent AHA president hat as you think about impact into the broader community. Principle number 3 was the NIH, in coordination with others, should play a larger role in the translation of evidence into practice, including more funding for implementation research. What were we trying to get at there, Joe?
I think that's a very important topic, right? So last night I was talking to one of the executives at Eli Lilly, and he was telling me that the GLP-1 drugs, which was discovered internally within Eli Lilly, took them about 20 years to develop. I think most of us think that it was 2 to 3 years, and go to the clinic and voila, New England Journal papers. The point I'm trying to get is all these take time. If you have great basic science, but then without on the back end, if you don't have people who can implement this in terms of doing a well-designed randomized trial, figure out what the right patient populations are, figure out the study cohorts then whatever basic science and discovery you have cannot be translated. From my vantage point, there's also a gap in between, which in the Silicon Valley we call it the Valley of Death, in which you have very nice basic science discovery, but you don't know how to file the patent, you don't know how to get money from the venture capitalists, you don't know how to get your set up your phase 1 trial, phase 2 trial, to attract the big pharma to come in at the phase 2, phase 3 trial. I think the NIH, to its credit, they've been trying to do that. The NCATS is one example, the National Center for Advanced Translational Science. And also, NCATS is fitting somewhere right exactly what I described. And then the PCORI and other large organizations are toward the end. But this is a whole ecosystem that all of us need to line up and learn from each other to deliver the best science that we could give to the patients. And this is what we're trying to get at for the statement number 3. Yeah.
Svati, let me ask you, because you made the comment earlier in our conversation about you're on rounds this week, and every interaction in some ways is guided by science that NIH, AHA, other funding agencies may have supported. An interesting stat that I've read recently that I've been re-quoting is that something like 85% of the drugs on the market can trace their origin in some way to an NIH grant, either a pathway discovery, a molecule discovery, a new mechanism of action discovery, but something. What do you think of, Svati, when you think of implementation science?
As Dr. Wu was saying, sometimes you can't predict what's going to be the impactful science, right? Bob Lefkowitz, who's a Nobel Prize winner, who is at Duke University, likes to give a talk to to us in cardiology about how to deal with failure and rejection. He has a letter, it's a mimeograph, right? Because it's from a long time ago, that says biased G protein receptor signaling is not a field you should pursue. That's a dead field. And then you think about all the drugs, right? What 50% of drugs that are influenced by that discovery. Broadly thinking about the diversity of science is really important. And Dr. Wu has emphasized that a couple of times. In that space, however, though, we have these valley of deaths. One valley of death is, they say it takes 17 years to take a discovery and actually have something that can go to a patient. But then there's a second valley of death, which is even when you develop something that can go to a patient, how do we actually get it to our patients, right? Including patients who may not have access. So to me, implementation science is the study of the methods that it takes to figure out how to get those therapies to patient, that second valley of death, as well as I think implementation science actually is that implementation, the actual implementation and dissemination of those therapies, of those risk scores to our actual patients and making sure they're getting to everyone everywhere.
Yeah, that's such a great description of the whole process. And Adrian, I'm going to go to principle 4 with you because I know that in your leadership role at Duke, you care deeply about training the next generation. And principle 4 was the NIH should continue to build and support the biomedical research workforce with funding and training opportunities. In some ways, that's self-evident, right? We want to support young people, but can you maybe put the emphasis on this for us as you look at where the world is going with regard to the need for the next generation?
Just this week, I was meeting with fellows, and we were talking about what's going on in the world. And one of their worries was what's going to happen to people like them falling through. They're making choices because there are pathways that NIH and AHA has opened up for research careers that are embedded in healthcare or clinical centers like Duke or Stanford and Cornell. But if there's no pathway, how are they going to actually take forward their creative energy and interests in discovery, clinical research, and broadly science? And so it's really critical to have those training opportunities and support, as well as actually supporting loans that they may take on as part of their medical careers.
That last piece is so important, not just thinking about training for grants, et cetera, but to help them get to that next stage of their career, which involves some of the personal things like paying off educational loans, et cetera. Joe, I'm not sure I've met anybody as passionate about young people as you. And throughout your tenure as the HA president, you talked about it constantly. When you were the research committee chair, you talked about it constantly. And as you know, when I was at Stanford, my office was across the hall from a lot of your laboratories. Your trainees have this great saying. So I said, what does Joe Wu teach you? They said it's to work hard, to work smart, and to work together. Talk about that, Joe, and talk about the critical nature of the NIH and supporting all of those young people that were in your lab.
I pride myself for the trainees that I've trained to become PI. By my last count, we have about 57 trainees who are now PIs, principal investigators. I think it's important to have a pipeline because sooner or later I'm going to retire. But then without the pipeline coming in, who's going to be teaching our future generation how to do science? My analogy is akin to a karate dojo, in which you go to a karate dojo and your sensei, your instructor, is a yellow belt. Well, there's a very big difference learning how to do karate, practicing karate from a yellow belt versus a 5th-degree black belt. And so if we don't have a new generation come in to replace us, then the quality of our research goes down. There's no reason for other trainees from throughout the whole world, Europe, Asia, South America, to come to the US to learn. They might just start learning at their place. We lose our preeminence, we lose our dominance in this area, and I think it's going to have a lot of trickle down effect.
Thanks, Joe. And yeah, and you've been a champion of bringing people from around the globe to study with you, and I think that's an important component of how we do science is to take the best from around the world. And one of the great things about the HA grants, unlike some of the NIH grants, is the AHA will actually support people from around the globe, and which I think is a way that AHA and NIH work well together. All right, we got one final principle, and I'm going to give each of you a chance to comment on this. In some ways, this is like the mom and apple pie question. We'll start with you, Savati. Principle 5 is a predictable, robust, and sustained public investment in biomedical research should be a national priority. Savati, make your case for that.
Yeah, I'm going to take the lens of training the next generation of workforce. There is attrition in science, as Adrian was talking about. There's attrition in people who want to pursue research careers, whether you're a PhD or an MD. We saw that attrition before our current environment. I really think this is a national emergency. This is a critical need. We're going to lose many generations of scientists, and we don't know what kind of incredible discoveries those scientists would have discovered. If we do not have predictable, robust, and sustained public investment, people are not going to pursue research careers. The unpredictability of those careers is making people not want to pursue them.
I like the way you said it. I've thought about this since the post-World War II era as as sort of the societal pact amongst four parties, right? It's been the NIH, it's been the research universities, it's been the industry, and it's been the philanthropists. And you put all of that together, and it's created a biomedical research enterprise. I've been using the phrase lately, if you really do care about America first, you should be investing in science because there's nothing that we are better at than biomedical science. Looks like you're all nodding, so I've made my point. Adrian, give us your pitch on a sustainable future.
It's also economics. And so, like, if you talk about a sector where America has distinguished itself over decades, is the world's leader, people come to America to train with the best, to develop science. And also, that actually has a huge impact across the US economically. Every corner of the US, it is a really important area. And that's also why historically there's been such great bipartisan support over the years for the NIH and also science in general, because it has an economic impact in every corner of the US.
Yeah, we actually mentioned that in the paper. For every dollar of NIH funding, there's a lot of dollars produced of economic impact in a community, and that's every community across the country because there's thousands of investigators. Joe, as the driving force behind this paper, I'll give you the last word on the importance from a national priority perspective.
This is something, as you know, I feel very, very passionate about. If we don't invest in science, we lose our edge in biomedical research. And once we lose our edge, again, there's no reason for other people to come to the US and do research here, stay here, contribute to our economy, contribute to our science. So, you know, this is a generational threat, and we need to understand that. And I would hope that all of us talk to our congressmen, talk to our donors, academic leaders, and our friends and relatives to convince them how important this area is.
Well, this has been a fantastic conversation. I hope that our viewers will take the opportunity to read the principles of the future of biomedical research and the optimizing the NIH from the presidential advisory from the AHA. I want to thank my colleagues, Drs. Shah, Wu, and Hernandez. Shah and Hernandez from Duke, Dr. Wu from Stanford. And thank you really for both contributing to the paper as well as contributing to this dialogue, which I think is going to be an important national dialogue. And for you, our listeners, I want to say, please let us know if you like this. Did you like the discussion? Did you like the topic? Are there things that we should add? Are there things that we should be pursuing in the future? Please leave your comments. Give us a thumbs up or thumbs down if you didn't like it. But let us know what you think, because that's how we get better shows in the future. So signing off for Medscape Cardiology and the Heart Dog Award, I'm Bob Harrington for Weill Cornell Medicine. Thank you, Savati, Adrian, and Joe.
Thank you, Bob.
Thank you, Bob. Thank you.